Welcome. Welcome back to night 2 of Doctors of Nursing Practice Week, sponsored here by DNPs of Color. A couple of announcements. Please be sure and use the chat to drop your questions in there, and then we'll have a Q&A after the talk. And I'll turf it over to Dr. McCamey.
Did you want to introduce yourself, Dr. Kesten?
Oh, sure. Yeah. My name's Dr. Karen Kesten. I'm on faculty at George Washington University, and I'm delighted to be here today.
Yes, thank you so much, Dr. Kesten. Everyone, I'm Dr. Danielle McCamey, and I'm just going to give you all just a brief overview of National DNP Week, how it came here, like what's the theme, and invite you to learn more about how you can get involved. So this year, National DNP Week, this is our second year, and it's October 19th through the 25th. And so the story behind National DNP Week is funny because last year, myself and Dr. Stephen Davis out of Georgetown, we had just completed a webinar that was focused on the impact of DNP prepared nurses. And as we were preparing for that presentation, we realized it was the 20th anniversary of the DNP degree. And another one of my colleagues, DJ Kirk, we were all just kind of like, oh, yeah, it's the 20th anniversary. We should do something. And me being very action oriented, put together National DNP Week because I looked at the dates. So October 19th is the official founding day of DNPs of Color. October 20th, we are coining as National DNP Students Day. And then October 25th is the actual date back in 2004 where the American Association of Colleges of Nursing voted to endorse the position statement on practice doctorate in nursing. And 2024 was the 20th anniversary of the degree. And since its inception of the position, since the endorsement of the position statement, there are more than 73,000 nurses that have their DNP degree. So it made sense in my mind to make it a National DNP Week, starting off with National DNPs of Color Day and ending with the official date in which the DNP degree was endorsed by AACN. And so last year we celebrated the 20th anniversary with a virtual happy hour, and that can be seen on YouTube. If you scan the QR code there, it'll bring you up to the full virtual happy hour. We had many speakers from different points of DNP history, and also we had a DJ and dancing because anybody that knows me, there's always got to be music and dancing. And it likes to show the video, which I don't want to show the video. All right. And so, again, just reiterating, October 19th is National DNPs of Color Day, October 20th, National DNP Student Day. And then just going over our theme where practice meets power, DNP's driving change. And so we felt like this theme was important to celebrate the unique impact that DNP professionals make. And so breaking it down, we felt like this was the perfect intersection because DNPs are uniquely positioned to understand hands on clinical expertise and understand how to fuse that with healthcare leadership. So we felt like this theme was powerful in amplifying how we are able to transform healthcare. And so when you think about practice, we think about real world clinical experience, evidence based knowledge that gives the GMP prepared nurses credibility and a special insight into actually what actually works for patients. So from bedside to boardroom, we know what really matters. And so power. When you think about the advanced education that we have, it allows us opportunities to hold various leadership roles. And with those leadership roles comes influence. And with that influence, we can share our insights to make some systematic and systemic changes to improve healthcare systems and communities and beyond. So when you add up education, our experience, it really shows our impact. And driving change, we don't follow trends, we make them. Every DNP prepared nurse that I know has had to make their way in some way, shape, or form in being innovative. And with us, we're able to identify problems, develop solutions, and make healthcare better for everyone. We're change makers, not change takers. And so our impact with this theme is just amplifying us and our leadership and our professionalism and how we're able to fuse both of those and bring in the heart of bedside care and the strategic thinking needed to solve big healthcare challenges, which is perfect for showcasing the real impact DMPs make every day. So happy DMP week, everyone, and I hope you enjoyed tonight's special presentation by Dr. Tracy Wilson. Let me stop sharing my screen so she can get set up and I will read her bio. Dr. Tracy Wilson has over 22 years of experience in healthcare and patient advocacy with expertise in clinical education, family nursing, and interdisciplinary course design. She holds a DNP from Belmont University, a postmaster FNP certification from the University of Kentucky, and a Master of Science in Bioethics from the Tulane School of Medicine, as well as a MS in Nursing Education from Bellarmine University. Currently, she works as a medical science liaison at ARS Pharma, focusing on FDA approved product for allergies and anaphylaxis, providing medical education to key opinion leaders and healthcare professionals. Previously, as a field medical director for antivirals at Pfizer, Dr. Wilson launched 6 new products and contributed to healthcare disparity initiatives. She's a recognized speaker and panelist with numerous awards, being inducted into the Fellow of the American Association of Nurse Practitioners, the President's Award from the National Black Nurse Practitioner Association, and the Impact Award from Pharmaceuticals. And then also, she received the inaugural Doc Daisy Award for Advancing Health Equity this past weekend. As both a nurse scientist and industry nurse practitioner, her powerful voice and clinical insight have already accelerated adoption across healthcare systems worldwide, proving that when nurses lead, the world listens. And without further ado, Dr. Wilson, the screen is all yours.
Thank you so much. Can everyone hear me? I just wanted before. All right, let's go.
Tracy, you're on mute, and we if you put it in presentation mode, because we see it in notes mode.
Do me a favor. Can you make me a co-presenter on here? Because it's muting my line every time I go in to show it. We're good to go?
Yeah, we made you a co-host.
Okay, awesome. Let's see if that fixes it.
Yeah, I don't know. It was working for let me can you unmute yourself?
Can you all see the screen or is the screen gone now?
It stopped sharing.
Yeah, it's muting the line every time I go into it.
That's weird. It was working when you before we opened up. Let me just
I
plug.
hate this. All right, I think we're good to go. So again, Dr. Tracy Wilson, happy to be in front of you all to talk about this very important message. I will make sure that you all get the actual slides from me. But again, this conversation is important because medical gaslighting is considered a health disparity driver. If you can go on to the next slide. So just to begin, I don't have any conflicts of interest, and the thoughts that I'm sharing with you today are thoughts of, are my own thoughts and not those of my company. So how did this all start? So I'm showing you a picture of my mom with my sister. And if you can think about your own personal situations, me growing up, I said to my mom at one point after she had a hysterectomy, Mama, what does it mean when your ears start ringing and your eyes get cloudy like a TV? And it was because I was about to faint because I was trying to be her caregiver at that particular time because my mom at the age of 8 had a total hysterectomy. And so I'm trying to take care of her and I'm about to faint because I'm cleaning her wounds. So this is where my passion around advocating, even at the detriment of me, that's where it started, was trying to take care of my mom at the age of 8. If you can go on to the next slide. So the picture that you see here is of me graduating from nursing school. But if we fast forward to the year 2015, in 2015, I was a nurse practitioner. Have been practicing for several years, and actually diagnosed with strep and flu at the same exact time. And so I went to the ER because my symptoms were not getting better. I was having headaches. I suffered from migraines, but these were different. This was feeling different. And so I went to the local ER and explained to the doctor, like, I just don't feel good. I have strep and flu. I have these headaches. I have neck pain. I just don't feel good. And so she was like, oh, it's just complications, from, the strep and the flu. So, no big deal. And I remember asking her poignantly, do you think this could be meningitis? And her exact response was, I remember to this day, I still can see her face, was, no, you're not this sick. No, it's not meningitis. I see meningitis all the time, and you don't have, the types of symptoms that the patients that I'm seeing coming in. And I asked her one more time. I said, "Are you sure?" I ran through the symptoms again, and she's like, "You know what? I'll do an X-ray of your neck, but I'm telling you, you don't have meningitis." And so she sent me home, even though I told her I didn't feel comfortable with going home. She sent me home. And 3 days later, I found myself back in the emergency room, a different one, because I knew not to go back there, and telling the same thing to another ER physician. And this ER physician actually listened to me. And they actually did what was supposed to be the standard of care and protocol and did a spinal tap. And lo and behold, I had viral meningitis. I possibly wouldn't have been with you all today had it been bacterial. But thank God, God was with me. He protected me. So that's my experience with medical gaslighting. I'm sure many of you all have this, you have similar experiences. I want you all to share those if you feel comfortable within the actual chat, and we'll get to that a little bit later. We'll go to the next slide. So this is the agenda. Not going to read through this. You can go ahead, but really, I want to leave you all feeling empowered about what medical gaslighting is, how to identify it, what's the prevalence around it, and how can we actually make a difference in this particular area. If we can go to the next slide. So this quote actually moves me whenever I'm doing this kind of talk. I like this quote from Dr. Martin Luther King, and it talks about that of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And that's why this conversation is so important tonight. Let's go to the next slide. So, what is gaslighting? So, gaslighting, as you can see here, the actual Webster Dictionary definition of it is psychological manipulation of a person, usually over a certain amount of time, but usually a long period of time, that makes that victim think like, "Wait, am I crazy? Like, I know what I'm thinking, but they're making me think something else." So the person is left feeling confused, loss of confidence, self-esteem, and actually can make an impact on your mental health. When we're talking about the medical gaslighting, then you can see with medical gaslighting, it's the same experience, but now this is at the hands of a healthcare provider. And I know we don't want this to happen, but it actually really occurs more often than you think. If we go to the next slide. Is it showing up? Yes. Okay. So if with gaslighting, it actually, the term came from a movie back in the 1940s. And if we can click on it, it'll go through that video. It won't play. If it doesn't play, no worries. Well, I'll send you all the link, where you can have the link to the actual video. But it talks about what gaslighting is, where it came from, and talks about the movie in particular, where a woman who was married to a man actually was messing with the gas lights in their house to make her feel like she was going crazy. So that's where the term gaslighting actually comes from. If we go to the next slide. So what's the prevalence for gaslighting? So there's some data out there that actually talks about that 75% of the US adults don't even know what the term means. So even for me, when I do this talk, a lot of people either have casually heard of it or they've never heard of it before. One third of females, 24% of males have been called crazy or insane in a relationship. Again, that same premise of doubting your reality, someone making you feel like your reality is not true. Approximately 25% of males and females have called a significant other crazy. 71% of US adults believe that both the physical and psychological abuse should be taken with equal seriousness, and that nearly half of women, so we're talking about 46%, have been psychologically abused at some point in their lifetime. Let's go to the next slide. So this was a survey that was actually done by She Media, and it was over 1,000 participants, various socioeconomic backgrounds, race, ethnicity, you name it. But this actually asked them particularly about issues around medical gaslighting. And as you can see here, some of the things I just want to point out is that 72% felt like they had been a victim of medical gaslighting, that 66% struggled to accurately describe their condition during an appointment. So we've had patients, right, that are in front of us and they're trying to describe what's going on with them, and that they have that difficulty explaining it. But if they don't get the time to explain it, that's going to cause issues. 71% of total respondents and 82% of the LGBTQAI respondents have been told by a healthcare provider that their symptoms were made up. And this actually, with parents, 25% are more likely to question themselves after a healthcare interaction. So, as we can see, this is a really big issue, and a lot of people have experienced it. Let's go to the next slide. So it actually, if we can kind of think about it, medical gaslighting has been going on for centuries. So we can take it all the way back to slavery, all the way back to Anarcha, Lucy, and Betsy. These women who have been called the mothers of gynecology, they, due to the brutality and torture that they actually endured under the guise of medical care and experimentation at the hands of Dr. J. Marion Sims. And if you don't know who he has been considered the father of gynecology. But in order for him to do this, he was doing this type of experimentation on the slaves, and these were some of the women that he did it on. And so I would postulate that medical gaslighting, due to their disregard of their concerns, their humanity, voices, screams, this is the origin. This is where it began even back then. And you can see in the slide that it actually talked about 70 slaves actually underwent this procedure, and it was fistula repairs that he was actually trying to do. So let's talk about this a little further. Next slide. So obstetric gaslighting, and we know that we're living in the time where we're really trying to bring awareness around maternal mortality. And obstetric gaslighting is actually a part of that. So we can see this with our infant mortality being linked to the treatment of the women like Anarcha, Lucy, and Betsy. So, gender-based subordination of obstetric patients during pregnancy and childbirth and postpartum. Again, where we know that these mothers are being ignored, they're not being heard, they're raising awareness about what the symptoms that they're having. but they're being dismissed. And this lack of care, this lack of listening to them is a part of why the maternal mortality rate is so high. So let's look at some other stories. Next slide. So I'm not going to play this, but if you have not heard the story of Kira Johnson, she was actually a mother, well educated, had her life in front of her, married, had one child, spoke multiple languages, and went in to have her second child and died there. Actually, there was an episode of The Resident in 2019 that actually covered her story, and her husband, Chad Johnson, has created a foundation in honor of her name, trying to bring awareness to Black maternal mortality. Let's look at the next slide. If you have never seen the story of or this documentary, Aftershock, I would beg you, please, please, please go and see it. This actually covers the story of many, many different women. I think it's either 3 or 4 different stories of women. Kira was actually a part of this documentary, or her story was a part of this documentary. But Aftershock, and it talks about Black maternal mortality and how things just go awry, and how it most, I think it's close to like 80% of these issues are preventable, just by if we listen to the patients even closer. So let's take another look at some other examples of medical gaslighting. So research has kind of shown that with long COVID, again, the delay in treatment, these patients have COVID, but then they're going back having these really kind of ambiguous symptoms. They are being ignored. Breast cancer diagnoses. We know, again, with people of color, that the delay in treatment, that, a lot of their concerns may not be addressed because of these issues. If you have not heard of Serena, her actual issue when she was having her first daughter, Olympia, she had this experience as well too, where she was not being heard, had a long history of PEs, and went in, and when she was having, after she had her, was complaining about chest pain and difficulty breathing, and they didn't listen to her for hours, and she had to fight for herself to be heard and for them to actually go ahead and do testing. And lo and behold, she had many, many, many PEs. And then if you have not heard of Dr. Susan Moore and her story during COVID, it is really, really difficult to watch, because she actually videotaped herself in the hospital talking about the care that she was being received by the clinicians there, and they were not hearing her. And she ultimately passed away because of this. If we can go ahead and go to the next slide. So who's at risk, right? So who are we concerned about when we're dealing with medical gaslighting? I will say it's anybody. It's everybody can experience this. But some other groups that have a little bit more of a higher risk of experiencing it: the vulnerable, elderly, disabled, women, people of color, children, and well, parents of children. They actually are at a greater risk of experiencing medical gaslighting. Can we go to the next slide? So why do we need more healthcare providers of color? And how could this be linked to medical gaslighting? We know that the research shows, and as you see the stats there, that 22% of Black adults and 29% of Hispanics and Latino adults share the same race as their healthcare provider, compared to 3/4 of white adults share the same race. So the research has shown that if you're cared by someone that looks like you, that identifies with you, that the care can have more increased outcomes just by having that likeness. And so that's why, by having someone that looks like you, that's taking care of you, that they may listen to you even more, and actually provide that more enhanced care that you're looking for. If we go to the next slide. So, how can healthcare providers help eliminate this? So, us that are clinicians, nurse practitioners, nurse specialists, other advanced practice providers, how can we help to avoid this? One, be familiar with the communities that you're taking care of and the patient population and where they're coming from. Again, that cultural awareness and that cultural sensitivity, that's going to make a big difference in making sure that those patients are being heard and seen. Appropriate health literacy for patients, we know that we need to make sure that the information we're providing to them is at the sixth grade level. I think there's even some data that says that it may even need to be more to the fifth or even fourth grade level in a language and learning modality of their choice. So making sure that we're giving the information the way that they want to see it. So not everybody is an auditory, not everybody is a visual. Some people want to be hands-on. So making sure that you're giving information in those modalities that they're wanting to choose. I love to teach back. So, I know all of us that have been educators or that are in education, we know about the see one, teach one, do one. So we know we want to make sure that we're giving the space for these individuals. Let me see if you really have learned what I've shared with you. I put on here about the example of House and its connection to Teach Back. If you haven't ever seen the episode where you have the older lady and she is telling House that he's asking her, well, do you use your albuterol, your inhaler? And she's like, yeah. He was like, well, do you know how to use it? And she's like, of course I do. And she grabs it and she uses it as perfume. That's the importance of making sure you do a good teach back with your patients, because some of them will tell you they know what they're doing and they don't. Train non-licensure staff to assist with additional skills and triage to help the HCP. That may give you more time back with your patients. And again, that active listening. I think if nothing else we don't do, I think as nurses, we are really good with that active listening, therapeutic communication. So I take pride in that. And one of the classmates that I had when I went back to school to get my master's in bioethics and medical humanities, she actually mentioned about the 90-second pause, which I loved it, which is basically that the first 90 seconds of any visit, stay silent. Let the patient just talk because they're going to tell you what you need to hear, probably in that 90 seconds. So just pause. Don't say anything for 90 seconds. The next slide. So again, how can we help to eliminate? For my own personal experience, for my family members that have experienced this, one, bring a family member to all appointments. Again, when you're in the thick of it, I know with my husband, when he was diagnosed with multiple myeloma, having me there as his ears, he's not going to take everything in because it's coming at him at 1,000 miles a minute. So having someone else that can hear that information actually could make a really big difference for you. Write down questions before you go. Actually start brainstorming. What is the things you want to know? Because again, in the middle of that appointment, you may not actually remember some of that information. Do not leave the appointment feeling unsure or unheard. That's your time. I like to look at it. You paid for this 15, 20 minutes, and I'm going to use up all of my 15, 20 minutes. So I'd say that to you all. Make sure that you are giving your patients the grace and the time that they paid for. And then you, as clinicians, make sure when you're having your appointments that that provider is giving you that same grace back. And then follow your instincts, trust your instincts. Your gut knows you better than anyone else. And then lastly, but not least, seek a second opinion. I like to think of it as that if you're not hearing what you want, if you don't feel comfortable with the provider, if you just don't feel seen or heard, go and get that second opinion because it could mean your very life. Let's go to the next slide. So, in summary, as we can see here, that we know as healthcare providers, we're in the thick of it. We know time constraints are there, but we need to make sure that our patients are leaving our appointments feeling valued, heard, seen. So, you make sure that you're doing that for your patients. You make sure that when you go to your doctor's appointment, that you feel that way. And then we can hopefully, at some point, this term of medical gaslighting won't even be an issue. So I thank you for your time. I'll now turn it over back to you all for you all to ask me any questions that you would like.
Please feel free to drop your questions and comments in the chat. We did have one question during the presentation, Dr. Wilson, requesting access to the slides so they could watch the videos, and I reassured them that you were going to be sharing that with us.
Absolutely.
So thank you. That'll give us the full experience.
Absolutely. I will definitely do that. Is there anybody on here that actually have experienced medical gaslighting or a family member has experienced it and would like to share?
This is Devin Nixon. I want to say, Dr. Wilson, that was wonderful. One of the things that you said that I really appreciate was to know the communities that we work with. I think sometimes we oversimplify and think of a particular community that's not been heard. But we all live and work in communities, and it varies who's represented. Um, a quick share about a family member, my mother. It was 62 years old in 2013. My brother took her to the ER. She couldn't breathe. They sent her home with an inhaler. She's not an asthmatic. She wasn't sick. She was a very classic heart failure presentation. But my brother called me and said, she still can't breathe. What do I do? Um, and I said, take her back and ask for an echocardiogram. Oh, there goes my low blood sugar. Sorry. And a B-type natriuretic peptide. And they did the test and ended up shipping her to the hospital where I worked at in another town. It was really, really frustrating because everybody doesn't have a nurse practitioner in their family. And so, your tips about presenting with a family member, a friend, or somebody who can listen and I think we all know folks are less likely to be mistreated when there's a witness or somebody with them. So I just really appreciated the way that you laid all of this out from the history to the present and the teach back. Thank you so much for sharing.
Thank you, Dr. Devin. I appreciate you.
I would like to share, if possible. I'm Dr. Kimberly Hollis, and this term gaslighting. I'm so happy to hear that term, because I think back many years ago, my own sister was 19 years old, in college, and called me, and at that time I was not a nurse, and she told me that her abdomen was like twice the size, but she didn't hurt or anything. And so I told her to go to the local emergency room, and she did. And when she called me back, she said, well, they told me that I probably have gas and that it should pass in a few days. Well, in a few days, it did not. And her abdomen continued to expand. And I told her to go to a different emergency room. And she did. And she was diagnosed with ovarian cancer at 19. She had to have a total hysterectomy. I'm very I didn't think about gaslighting, didn't know really what questions to ask or anything, but I'm glad that she went to that second emergency room, because I mean, otherwise it probably would have went on and on. I mean, she was young, I was young at the time as well, but she is still battling cancer at the age of 50 now. So happy to hear this term, gaslighting.
No, my
Thank
pleasure.
you.
Thank you for the story. Thank you, Dr. Hollis. And I'm sorry that your sister, had to go through that, Dr. Devin. I'm sorry, the experience, on your end. Again, that's the reason why we're needing to bring awareness, because again, a lot of people don't know this term, but they know the experience. They know when they left, they
Oh,
didn't
of
feel
course.
so
Yes.
no,
Thank
thank
you
you.
so much.
Mhm.
I had the experience with my sister. She had been complaining of like neck pain and like bilateral numbness and tingling in her hands. And so she went to go see an orthopedic physician, and they kept saying it was carpal tunnel. And I was like, where is in the world is carpal tunnel with bilateral weakness and numbness and like neck pain at the base? And he was like, oh no, it's carpal tunnel. We're gonna set her up for carpal tunnel surgery, blah blah blah. And so I was like, hold that thought. And then I ended up taking her to one of my system's hospitals, and it was a neurosurgeon, Dr. Calhorn, love him. And he examined her and was like, let's get some scans, and ended up scanning her neck. And she had cervical spine cord compression, that she was starting to have some signal changes that was going to turn into some motor changes. And so she ended up having to have C-spine surgery to release the compression of her spinal cord. And so I went back to that orthopedic physician and I let him know that his misdiagnosing of my sister could have potentially caused her to be paralyzed or even worse. So,
Thank you. Thank you for advocating, for your sister, because it makes me angry that we even have to do this, that we even have to make you, I don't know any other way to say it, but make you do your job.
period.
And so, even in my own personal experience, I went back once I was out of the hospital, because I was admitted for 4 days. I mean, it was really traumatic, even to my family, to me. And I went to that hospital, and when I say I pulled everybody from the head of the ER to the chief nursing officer, because I wanted her to know that her lack of listening could have killed me, and I wanted some change somehow. And so, even to the point of, I had insurance, but I didn't want my insurance to pay for that bill for the ER visit. So I wanted them to write that off. We wasn't going to pay anything, and that's exactly what they did. So that's what I want. I want us to feel empowered that we can advocate for ourselves, but advocate when you see something not being right. Again, when we talk about the code of ethics tells us this is exactly what we should be doing. This is a part of our job. So, I see RWC Powers has her hand up.
Thank you, Dr. Wilson. Good evening, everybody. Well, could you hear me?
Yes.
All right. I would like to start by wishing everybody happy National DNP Week. It is amazing to have colleagues with the same degree online. I know we all work hard for that degree, and to see this whole movement, so happy. I wish you everybody all the best, and I'm so proud of all of you, your accomplishment. But talking about the topic, and Dr. Wilson, I also want to thank you for being passionate about this topic, because sometimes, as much as we see it all the time, and it's obvious in the places we work at, or even in our own personal experiences, it becomes hard to talk about certain things, especially with all the things going on in the world now, right? So we're trying to stay away from equity and all those things. But at the end of the day, I think we need to talk about it, because we have the opportunity to do something about it and talk about it to bring awareness. So I give you kudos to have a whole presentation on it. Thank you so much. I'm glad I didn't miss tonight. But just like some of you, and for those who have shared your experiences, thank you for sharing parts of your personal stories for us to hear what goes on, and to also realize that this is a widespread issue, and it's not just one person who has dealt with something like that. I had a family member who went to the emergency room with bleeding, and they put the urology Foley catheter in, and a physician put it in. When it came to removing it, the physician sent a message to a nurse to just yank it out. And I'm sitting there like, that's not gonna happen. Because I'm sitting at the bedside and I'm like, oh, hold on a minute. The nurse walks in and is like, I'm coming to take the Foley. I said, ma'am, excuse me, I work at this hospital. I'm a nurse like yourself. guess what? I became a nurse. I switched my profession from teaching into nurse. And after my mom died from preventable medical error. Okay, so if that's not enough, I'm actually not letting you touch any Foley here. So even if it means we will stay here for a whole week before they send a physician, then I expect the physician to come in and do it. So she goes back, calls the physician again, and the same thing, the physician said, we are very busy, this patient is stable, just yank it out. And I'm like, if I had not heard it myself, I would be like, oh, maybe the nurse is making it up. Because as a nurse, I was furious as a nurse. And I was furious as a family member. Because why did I hear it myself? I walked out to get ice for my loved one. And again, they paid the physician is calling back. And so I don't know how they had the phone on speaker. We all know nursing, we get busy sometimes. They were busy, it was a bar shift, and they had the phone on speaker. Oh boy, was I furious. I was so furious. So the bottom line, physician never showed up. The pressure that came with it, when I tried to hold my husband's hand, he said, babe, I cannot hold your hand because if I hold your hand, I will break your hand. And his body is shaking because why? Because the nurse, before I met this whole situation, the nurse had started pulling it up and couldn't do it because first of all, he went in with bleeding. And now there was a clot around it, so it was hard to come out. So the whole thing. So these whole things, as much as we talk about it, and it's not just a one person issue. As a Black woman, it was so hard for me because I knew these things happen. But just to hear physicians say, just yank it out, I kept asking myself, is this like, are we dealing with boxes or are we dealing with human beings? You can just yank it out because he's not stone. So, yeah, that was our experience. And it was a hospital I was working at. Then we came home and my husband said, I just want you to know that it was the grace of God because now there was a pressure that brought it out. So they thought I took it out because we're still trying to get a physician. He's bleeding. They've already moved it halfway and it's stuck. Okay, so and I'm like, okay, if I touch it to see the pain he's going through, I must as well take it out. But I can't take it out because I'm not the nurse. So at this stage, let me just let it be because if I touch it and something happens, they will blame me for it. So as a believer, I started praying. We started praying. My husband is praying. I'm praying. And then boom, we just see some force that brought the Foley out. And after that, he had some relief. But the nurses that came in, they actually thought that I took it out, right? But the bottom line is after that, when we came home, to just hear my own husband say that, I know that's a hospital you work at, but even if I pass out and I'm dying, please don't take me to that hospital. It broke my heart. It broke my heart because why? Because I go to work every day. First of all, the passion that brought me into nursing and made me switch from elementary school teaching to nursing is something that I take so serious, and I do my best for my patients, regardless of how they look like, their socioeconomic status. And so to witness that and hear my husband, I said to my husband, don't worry, you won't have to worry about it. Even if you're dying, I will never take you there. And I was also, shortly after that, I came out on medical leave, and I said, after my medical leave, I'm about to go out for surgery, but I won't even go back to the organization. I will look for a different place because I can't care. I can't sell something that my own family can buy. So, why do I share this experience? We're talking about gaslighting. The whole thing is, even though he was talking about how much pain he was in, it was being undermined because somebody is just saying that he was like to them. For a minute, I felt like my husband was just like a box, right, or a piece of wood to medical employees that we all take off to do our best for our patients. It broke my heart. So for me, any chance I get from those things, from my mom dying from preventable medical error 15 years ago, from my niece dying from preventable medical error, I mean, after in 2019, 8-year-old who went to the emergency room was given a wrong medication and ended up going into cardiac arrest and died. I'm so passionate about patient safety. And I always say that we talk about these things, right? We all sitting here, we've heard the stories, we've heard your own personal stories. I'm sharing mine, others are sharing theirs. I urge that we when we leave here, whatever we've heard here, when we get a chance, we talk about these things. The more we talk about how this has been other people's experience, it's not just like a theory or somebody putting a PowerPoint together or presenting something, but these are real things that people are experiencing, whether it's black, brown, green, blue, white, that some people unfortunately are experiencing. That is the only way that I think will bring awareness. Because I think yesterday I listened to a topic we had on this same platform. And one of the things, I'm not sure if it was this or something else I heard from, but I think it was yesterday's speeches that said, I believe somebody might have said something about sometimes we don't even realize, or the people doing it don't even realize those bias are there. I always put myself in it. We all have implicit bias. Some people don't even realize they're doing that. I urge everybody to be advocates. Speak out for that person, because sometimes we also witness it being done to another patient. But maybe you are the only person on that shift that may look different. Or regardless of whether you look different or you look the same, but you may be scared to speak up. But I urge every single person that when you have this chance to talk about these incidents, to speak up for safety, to stand up for that vulnerable patient who otherwise cannot stand up. Because deep inside us, when we sit at nursing stations, or some of us who I don't get to sit at nursing stations like I used to, but in those days, there are times you witness things that you know deep inside you that it wasn't the right thing to be said to a patient or a family member, right? So I just urge that everybody will be advocates and encourage other people to be able to stand up and speak up for safety, especially to the most vulnerable people that we serve. Thank you so much for letting me take a lot of your time.
I was like, all right, Dr. Powers, we about to wrap it up. So thank you for sharing. Dr. Wilson, do you have any final thoughts before we close out for tonight?
Thank you to you, Dr. McCamey, for giving me the platform to be able to share this information. Again, I'm very passionate about it, not only because of my own personal experiences, but because of family members. And again, when we talk about this, more people are going to be aware of it, so we know how to overcome this. So again, I celebrate you. I say thank you to you for this time.
It is an honor and a privilege. Dr. Kesten, do you have any thoughts?
Oh, I was thinking of my own advocacy experiences as a nurse at the bedside. We all have more than one story to tell, that's for sure. Did Devin Nixon want to say anything? I know she's been dropping some messages in the chat.
No, ma'am. This has been great.
Oh, okay. I'll read. She said, I keep thinking of Dr. Monica Lamore's words. We always want to legislate, but sometimes we need to litigate.
Facts.
Yeah. Thank you, Devin, for that. Thank you, Dr. Wilson. What a fabulous evening we've had and sharing these experiences and some great tips that you gave us in your presentation. We really appreciate your time tonight and your sharing of your expertise.
Thank you all. You all have a blessed night.
Awesome. Good night, everyone. We will send out the recording and post it on our page. And